Hello, everyone. We're so happy to have you here. Um, Welcome to our first Resilient Georgia General Meeting of the year. We're very excited to have this meeting and have some of our partners present about trauma-informed innovation in healthcare related work that they are doing. We are very happy to have Dr. Jordan Murphy ground us with this mindset. In a few moments, she'll be talking a little bit about what our title means and just kind of have us all be in that mindset as we go forward, hearing from all of our wonderful presenters. Just as a few reminders, we will be providing different content and interactive questions through the chat throughout the meeting. We encourage you to engage as much as you like, and with that, we will collect all the information that we put in the chat. So all of the content, all of the responses from all of you in the audience and all of our presenters, we will combine into a follow-up document that we'll send out after the meeting, and it will also be posted on our website along with the meeting recording, so everybody can have access to that. Thank you very much to Cami Wolf-Rice. Hopefully many of you received this in the mail from us. So her book, which I could not put down, Neha said the same thing, and then I read it and I just couldn't put it down. But her book, The Flight, that we've sent out over 50 copies of that to many of you that registered quickly for the meeting. So hopefully you received that, and please share it with your friends, family, partners. It's just such a wonderful read. And she'll be talking a little bit more about the work that she's done. As kind of an icebreaker activity, maybe the next slide, we have decided if you would introduce yourself in the chat and write a happy story in 3 to 6 words. So that can be something as simple as, I made it to yoga this morning, or I made it to my favorite coffee shop, got to daycare on time. Whatever happy story you have for today, please add that in the chat. So with that, I would like to introduce, like I said, Dr. Jordan Murphy. She's an assistant professor in psychiatric mental health nursing at Rosalind, or has a background from Rosalind Franklin University of Medicine. She has been a nurse practitioner for years and one of our core partners that provides so many different training resources to us. The community resiliency model training she's shared with all kinds of different populations throughout the state, children, adults, and we're just so happy to have her here to share more about the community resiliency model. I will kick it off to Jordan.
Thank you, Emily Ann, and welcome everyone. I'm just going to give a very brief introduction to trauma-informed healthcare. And I just have one slide, but before we advance to that slide, I just want to kind of set out the definition of trauma, not because we haven't probably heard that term so many times over the last few years, but just to kind of put it a little bit more in context of healthcare and what that means for Resilient Georgia and the regional coalitions. But trauma is a series of events that are physically and emotionally harmful, and they can have a lasting impact on our mental, our physical, our emotional, and our spiritual well-being. Now, if we think about our well-being, oftentimes the solution for our experiences of trauma tends to land in healthcare. Individuals often seek healthcare services and providers for access to care to help address many of our lived experiences of trauma. And so as that is often the case, it also is a challenge area for us as providers and also health systems. How do we address someone's lived experience while being compassionate and culturally relevant and linking them to services? And so what Resilient Georgia and the regional coalitions, and I believe there's 900 now community partners across the state who are all working to help address trauma and individuals' lived experiences in a way that is compassionate. One thing that I found is that a lot of the work depends so much on us supporting one another. And so I'm really excited to hear all of the presenters who will talk about how they've developed and rolled out innovative solutions within their healthcare systems, private practices, and even family experiences that have informed a lot of work in healthcare. Before we do that, though, I want to look at the Resilient Georgia Roadmap slide. I really like this slide because it gives us an overview of Georgia's ecosystem and how we are working really hard, and all of you are working so hard to become more trauma informed. And so the idea about being trauma informed is that it is an ongoing process. It requires an organizational paradigm shift. And also it requires a lot of collaboration between different sectors. So in looking at this image, you may see your own sector. We know that we have so many individuals joining here from faith-based groups and schools and businesses, and of course, healthcare. So one interactive question that I would like to pose to the group, does your organization have an established partnership currently with any of the sectors in the image? And I believe there are 12 here. So we would love if you would put it in the chat. How many organizations are you partnered with across the different sectors? Is it 1, is it 2, is it 12 different sectors that you're partnered with? All of them. 12, 10 plus, 12. It's very impressive. All 9, all 12, 10, 7, too many to count, all of them. So I so appreciate how it has not been that long. And as you can see the numbers coming through, you all have been doing so much great work to get trauma-informed trainings and supports out across the region and across Georgia. And this is what collaboration looks like. And so we're going to hear from, again, hospital systems and individuals who have highlighted and done really innovative work to become more trauma-informed. And if by chance, although it doesn't seem like it, but if by chance you have not yet connected with a local hospital system or primary care office or a group of local providers as a part of your partnerships within your organizations, I hope that you all will get some innovative ideas and consider expanding your services in the next 1 to 2 years. And so thank you all, and I'll hand it back over.
Thank you, Dr. Murphy. So quick reminder, as you know, all of you as partners, we know you most likely know who we are. If you're new to our meeting and you've never joined us before, we are building a collaborative Georgia, trying to work with all of these sectors and getting folks to all talk the same language. We have over 900 stakeholders now. We'd love to hit 1,000. So if you have friends to join, to invite to the next gathering, please do. Our current footprint is on the map. We also have a lot of statewide efforts that are more than just these counties, but these are where we have our current coalitions. We are working hard to create at least 4 more coalitions by the end of the year to cover the spaces that are currently white right now. Next slide. And I know Dr. Constantino and Tammy are going to talk about this a little bit, and Pam, and at the end of our meeting, but quick shout out for the Reach Institute and our partnership with the pediatric, PHIC for short. We are going to host a Reach Institute PPP training at next month from the 19th through the 21st, and we hope you will share that with partners. It is a $2,000 value for physicians, nurse practitioners, and physician assistants to feel more comfortable treating mental and behavioral health in their offices. It's a wonderful training. Dr. April Hartman has helped us get this available for all areas of Georgia, and she's willing to share her experience with the training with anyone if you have a provider that has questions. So I will kick it off next to Miss Jennifer Hibbard. She's a licensed professional counselor and CEO of Viewpoint Health. She's going to be talking about their co-responder behavioral health unit. And thank you, Jennifer.
Hi there. Good afternoon or good morning, actually, still. Thank you so much for the opportunity to present. And I'm going to start off by sharing a little bit about how Viewpoint Health has approached our work with becoming trauma-informed care as an organization. Viewpoint really began this work over 10 years ago, and it's something that we continuously strive for. It's not an easy, simple process. You can't just take a training and then all of a sudden say you're trauma informed. So it's really something that every time we hire new team members, we are going through the process of making sure that everybody understands what trauma informed care means. And we actually make sure that we're using this lens in all of our interactions with clients when we're revising policies and procedures, developing forms, thinking about the way our physical space looks. So that's what I want to start off with. And then I'm going to also share what that looks like in action with some of our programs that we have. Next slide, please. So every contact with a client, we understand that we're either going to contribute to or detract from a safe and trusting healing environment. And of course, that's what we're going for. As a trauma-informed care organization, we recognize that past traumatic experiences have had an impact on the patients, on our providers, as well as caregivers. And we want to recognize our role in assisting our clients and the individuals that we served in making progress in their own life. And so everyone is important, whether you're a psychiatrist providing direct care, a front office person greeting a client, somebody in the back office billing, answering a phone about a question. Everybody is trained throughout our organization. Next slide, please. So the next few slides, I'm going to talk about how our interactions might be unintentionally causing clients to feel or maybe trigger a traumatic experience, and then also what would help make their experience in our services more supportive. So we need to understand as a healthcare provider that life situations might be contributing to a person's current situation. And we also recognize that people have experienced traumatic events in their lives, and it could cause them to be more sensitive to situations that might remind them of that traumatic event. And we have to recognize what our role is in helping to minimize whatever might trigger somebody to feel that distress. So any sort of interaction that might come off as impersonal, that could maybe be perceived as judgmental. So we want to strive for interactions that always express kindness, patience, reassurance, calmness, acceptance, and listening. Next slide, please. So again, unintentionally, our space might be congested or noisy. We might have too many signs that could be confusing. The furniture might be uncomfortable, or it might even just be laid out uncomfortably. For instance, if you have furniture that is in the waiting room where somebody has their back to another person, that might be uncomfortable for somebody. So really thinking about the placement, we want to make sure that our furniture is clean and comfortable, that what we put on the wall, it relays a positive message. And we also want to make sure that people feel like there's not that they're not in the wrong place. Wherever they come, whatever question they have, we're here to help you figure that out. So we want to convey that from the very beginning. Next slide, please. So we want to ask ourselves, are we asking questions that convey that something is wrong with a person? We're a mental health facility. We provide mental health and substance abuse services. And so we want to make sure that when we're asking a question, that we're not imposing some sort of judgment or even thinking about that person's difficulty only as a symptom, as a medical symptom. So instead, having that reframe as to what happened to you, asking questions with purpose out of understanding and curiosity to try to help understand what potential harmful events might be contributing to the person's current issues, and also recognizing that their symptoms are not just a symptom. It might be what they're using to cope and in kind of their strategy to help them deal with some of the traumatic experiences that they've had in their life. Next slide. So our own policies and procedures as an organization can also be contributing to some of the clients' concerns whenever they're coming in. So we have to ask ourselves, does this policy or procedure focus on the organizational needs or the client's needs? And we really want to put our client needs first. And we also want to think about our documentation and the way we have to take that documentation. And are we doing this in a way that is client friendly? For instance, is there a lot of paperwork that they've got to fill out beforehand before ever talking to somebody? Is there a lot of hoops that they have to jump through? Is the paperwork in a language that they are comfortable with and understand? So what helps with that is more sensible and fair rules that are clearly explained and focusing more on what we can do versus what we can't do. And one thing that we do is practice collaborative documentation, where we have transparency in our documentation. So when we're typing something in, we're sharing that information with the client so that they understand what we're documenting in their health record. It's about them anyway, so we want to make sure that they understand that. Next slide, please. So access to care can even be traumatic. And we're going to put drop a question in the chat here. 29% of people with serious mental illness have had police involvement as part of their pathway to care. So when you think about accessing healthcare, who thinks about going to the police or having police involved in that? I sure don't. But do you know the nation's largest mental health hospital? You want to put that in the chat and see if anybody can name that. Next slide will show who that actually is. It's actually the Los Angeles County Men's Central Jail. In fact, the top 3 largest mental health centers in America are jails. It's LA County, Cook County, and New York Rikers Island Jail. So that does not bode well for the state of mental health treatment in our nation. And we really need to start doing something different about that. And this is a long-term side effect of some policies that have been in place nationwide. And I'm hoping that we're really working on turning the tide there. And one of the little things that Viewpoint has been doing over the last year or so is if you go to the next slide, we'll talk about that. It's trauma, and I'm calling this trauma-informed care in action because we have partnered with local law enforcement with our co-response teams to embed a clinician in the police departments. So we've actually got 14 teams around the 3 counties that we serve. And this one that you're seeing pictured here is our partnership with Gwinnett County Police. So Gwinnett County is the largest county that we serve, and their police, the county police serve the unincorporated Gwinnett areas, and there's 6 precincts. So we've got 1 clinician in every precinct. So there's 6 teams. And the way that is structured, it's a licensed clinician that is partnered up with an officer, and it's the same officer. So you see here Pej and Tracy. Pej is the clinician and Tracy is the officer, and they make up a behavioral health unit. The 2 of them are partners, and Pej rides along with Tracy, and they respond to calls that have come into the 911 center, or an officer is on a scene and calls for the behavioral health unit, and they respond to the scene. And you might have even seen some of it on the news. If you click to the next slide, we've got a slide here that shows Gwinnett's police. Yeah, go ahead and click. There we go. Our Gwinnett Police mental health team helped the Greyhound bus standoff. If you remember, several months ago, there was a young man with a gun on a Greyhound bus, and it shut down both directions of 85. All lanes, both directions were shut down. The SWAT team was called, helicopters were there. It was a very dangerous situation. And Pej and Tracy, who you just saw on the previous slide, responded, and they were able to talk to the young man who was having a first episode of psychosis break and was terrified and scared. And I share this quote from one of the sergeants that was on the team, that was on the scene, because this quote from this sergeant shows that our trauma-informed care approach is now being accepted and utilized by the police partners, because this is very much a trauma-informed care approach. When he says, we knew that we had to quickly relay to him that we were there to help him and that we were there to make sure that he got the help he needed once he came off the bus. And it just, this is just one of the many interactions that we've had. We've gone out on more than 2,000 calls. And if you go to the next slide, you'll see some of our results. So this is just really something that our team is thankful that we have the opportunity to partner with law enforcement to do this work, because of all the calls that we go out on, 98% are diverted away from jail. And that is really amazing, because officers without a clinician, when they're on a scene, either they walk away and can do nothing, or really the only tool they have is to take them into jail and to arrest them with something to try to help alleviate the situation and make the situation safe. And for 98% to be able to be diverted, it's a huge, huge benefit to the community. It's a huge cost saving to the justice system, to the law enforcement system. And of those that don't, of that 98% that are diverted, this is some of our data here. 42% are just connected to services. They're linked to community providers that can help them. They're linked to housing resources or community resources, or enrolled in Viewpoint Health Services if applicable. 29% is resolved right there on the scene with no other further action needed. So that's also a huge chunk of the work that we do can just be managed right there on the scene. 19% is voluntarily hospitalized, where the behavioral health unit works that out so that they can take somebody right in. And then only 8% are hospitalized involuntarily, which, as a CEO that actually has a crisis unit, I was really concerned that if we were going to be diverting this many people and intervening really early on, that we would be filling up our crisis unit, which is a really limited resource anyway, but only 8% are going involuntary. So I think that is really a testament to the work that our clinicians are doing right there on the scene and connecting them to the care that they need. So thank you. I hope I stayed within my 10 minutes. I had my timer all set to go and then I forgot to click go. So thank you so much for the opportunity.
Thank you, Jennifer. You're fine. The whole presentation was so telling and shows how much work you've done in such a short time. Thank you very much. Next, we are going to hear from Cami Wolf-Rice, who is the founder and CEO of the Christopher Wolf Crusade and author of The Flight, My Opioid Journey. Cami?
Hi, thank you, Emily, and thank you to Resilient Georgia and the team. You all have been incredibly supportive. If you could go to the next slide, we're going to start with a video, please.
Christopher had big dreams. He wanted to be a Navy SEAL. He wanted to travel the world. He wanted to matter. We lost him at 32 to a drug overdose. It didn't have to happen. The English language provides a word for everything except losing a child. It's inconceivable. Christopher's addiction started innocently as a prescription for pain management and ended in his death. It takes something so horrific like losing a child to give you an understanding of how to save a child, a mother, or a father. With this understanding, we are humbled to announce our mission to prevent addiction from starting in the hospital. We call this position the Life Care Specialist. Currently piloted at Grady Memorial Hospital in Atlanta, Georgia, the Life Care Specialist works with your clinical team to create a barrier against addiction to pain medications that you may be given during your stay. Few people know that drug misuse often starts in the hospital during the pain management process. Prescriptions given to address a temporary pain can become a permanent, even fatal addiction. The Life Care Specialist represents an extra set of eyes paying close attention to your condition when you are in your most vulnerable state. We look forward to adding this position to healthcare facilities around the United States. But most of all, we look forward to saving a son or a daughter. We need them here so their dreams can one day come true.
I'm so sorry. That was a rookie move. I'm unmuted now.
You went back on mute, Cami, sorry.
I don't know why that's happening because I'm not pressing anything. We'll try again. Okay. In our society, we use coaches for everything. Executive coaches, diet coaches, workout coaches, football, baseball, right? You get the gist. But when you're in a health crisis, you don't have a coach. And so I looked at this position. There's so many lanes that you can go in when fighting the opioid epidemic. And I based this position on everything that my son Christopher did not have, on the multiple surgeries that he had 20 plus years ago that are still the issues today. This is our CWC healing wheel. So the Life Care Specialist first educates the patient if they have to be on an opioid, the dangers of staying on them long term, how to taper off. And then we provide pain management techniques and mental wellness skills. We've all been certified with the Trauma Resource Institute. I know many of you are certified as well with the community resilience model, because if you look at being in the hospital, you have anxiety, stress, depression, and PTSD. So it's very important to handle the mental side when looking at healing as well. Next slide, please. So we started in 2019, of course, right when COVID happened, so that made it a little bit more challenging. We have a research team at Grady Hospital. We would not have been able to do what we do if we hadn't had champions like the chief orthopedic surgeon and orthopedic trauma at Grady, Michelle Wallace, who you're going to be hearing speak after me. It took a team effort. We still have this research in place, and we did a randomized trial. And, as you know, when you're creating a new position in healthcare, data is key, but the psychosocial piece of it, the stories were so incredible. And since then, we've been able to also take those CRIM skills, and we've trained over 150 frontliners on the CRIM skills as well, because we know that they need that support. And so moving forward, as you look as where we're going to expand, and I'll talk a little bit more about this, we just received a private grant from a private foundation to expand the Life Care Specialists into rural communities. So we'll be rolling out into 4 counties in rural Georgia as well. We're excited because we have been published in 4 different medical journals. We're really making progress. So super excited. Next slide, please. Some of our initial study results, which the biggest alarm here was 70% of our participants, the hospital patients, did not know they were taking an opioid, didn't know basically what an opioid was. Once we explained, we had a situation where a man said, well, my wife is dealing with substance misuse and I'm taking home a prescription of narcotics. He didn't even realize that. So we were able to tell him how he could lock up his prescription medicine and how to handle that situation. The patients who saw a life care specialist in the control trial, 25% less opioid pain medication compared to the control arm. So we were really excited about that. A silver lining to also, we didn't realize how many comorbidities we were going to find out when spending that time with the patient, finding out that they have home insecurity, food insecurity, domestic violence. So we were able to get them the resources that they need so that they didn't slip through the crack. I think, what's been really great is sometimes patients just need a listening ear. They need somebody to validate their pain. And what's not in the study, in this particular study at Grady working with Emory, is the nurses are now asking, I'm going to wait and see that patient when the life care specialist comes in, because we've been able to build a trust and a rapport with patients when they've had a traumatic event, maybe a gunshot wound, a stabbing, a car accident. So it's really, really made a difference. So we're super, super excited of the results. Next slide. So we took some of these modules because I also work with another nonprofit. We focus with youth. And I was just like, how can we get this message out to youth? And so we just launched last month a care coach certification, and we taught college students on how they can be care coaches. Because to me, the secret sauce is youth training youth peer-to-peer. And so we took the modules that we trained the life care specialists and started training youth so that they could be care coaches. Again, not the whole extensive training that we train our life care specialists, but suicide prevention, how to have those conversations, giving them self-care skills. We've also been training Georgia peer specialists on pain management and on the CREM model. We just trained Hope Movement Coalition out of Arkansas. They have case managers that deal with the families that have been affected by losing their children and their loved ones. We got to remember all those people out there that are left dealing with the pain and the grief. And so we've just put them through the life care specialist curriculum as well. Next slide. And as we talked about earlier, it's all about partners. And that's what Resilient Georgia has been just so amazing, so that we're not working in silos. Lynn Patello introduced me to the dean of Mercer University. So we're now partnering on our rural initiative with the Georgia Rural Innovation Center, and we'll be hiring in those rural communities for the life care specialist, and we will be going into hospitals in rural. We'll also be adding a telehealth position where we're actually talking to patients prior to surgery as well, so that we can set the clear expectation of pain and how we can be there through the whole process. The other key point to the life care specialist is we do follow up once they've left the hospital to check in on them. How is their pain? How are they handling their opioid medication? Have they tapered completely off? And how we can continue to be a resource for them. Next slide. So I wrote a book. I never had any thoughts in my life that I would be an author, but I just felt like this fire inside of me that I was not reaching the masses. And I wanted the warning to become out there. And I'm quite vulnerable and raw about the mistakes I felt like that I made and what I could have, should have done. And really just as I share my journey, and people ask me, well, why did you use the flight? I had to go to an out-of-body metaphor to explain the loss of a child. And I use the flight as our journey of life. And we stop at different places: happiness, success, grief, illness. And you have to keep flying. So all the proceeds go to the charity. I appreciate, again, Resilient Georgia for sharing the book with the members. Thank you. I have QR codes in there that has a resource library in the book, so that it'll never go stagnant. And then, I would love it if everybody here would please, if you're on social media, please support us and share our educational posts. That would be most appreciated. Thank you again. Oh, my question for you is there a need for life care specialists at your local hospital?
Thank you so much, Cami. I think I know the answer to such important work, and we're so proud of you, and your strength is amazing.
Thank
Next, we're going to hear from Grady Health System and Michelle Wallace. She's the Executive Vice President and the Chief Nursing Officer, and she's going to be sharing about their trauma-informed frontline team.
Great. Thank you so much, Emily. So at Grady, next slide, please. We started, you heard about the great work that Cami has done, and really was our introduction into trauma-informed care at Grady. And we've really taken it a little bit of a step back for our leadership team. Next slide, please. And really focusing on our leaders and recognizing that we really needed to have a conversation and an understanding amongst our leaders before we took it down to our patient level. And so for us, we started with trauma-informed leadership at Grady. And really what we've been working through in training and education, and Dr. Sansonu has come and done lots of work with my team and others in the organization, is realizing the impacts, realizing how broad trauma is, and understanding how we can help support recovery, recognizing the signs and symptoms, and asking the infamous question of, it's not what's wrong with you, but what's happened to you. And we use that phrase around here quite a bit. Responding, looking at how we interact with individuals, our frontline staff, and even with our patients, and understanding how trauma may have impacted them. And then also, very importantly, is understanding that the actions and the work that we do can sometimes re-traumatize. And that actually will go down to our frontline staff and our patients, and understanding when patients come in crisis and how we react. And some of the things that we've always done just aren't the right things to do. And so that really is kind of our framework and where we started. Next slide, please. And so we understood that we have a need. At Grady, it's intense. You know, we have a very intense environment for our frontline staff, and we are busy. We are busy all the time, and we provide such wonderful care to our patients. But we've had some pretty big incidents that have happened here over the last few years. So 2019, we had our hospital flood, wiped out 6 floors. We're pretty resilient. We really came back and bounced back from that pretty well. But in a few short months after that, COVID hit, and we all know the impact of what that had. But the trauma that was created, both from a frontline perspective, the trauma that our patients were bringing in was just profound, and really had an impact broadly across every single person within our system. And then, of course, the racial and social inequity has always been a challenge. It's always been a problem, but really over the last few years, with some of the violence and some of the actions that have occurred, that have really just been brought to the forefront, and just really showed us and affirmed that we really needed to focus on a trauma-informed approach with both our staff, our leaders, our staff, and our frontline, and with our patients. Next slide, please. So what did we do? We did a couple of things. We launched a We Care Frontline program, and that actually started in 2018, 2019, right before the flood started, and I'll share a little bit more about that in a second. But we also worked with TRI, the Trauma Resource Institute, and brought the community resilience model to Grady. We did that through Cami's work with her team, as well as in training some of our own instructors, and then created an executive steering committee for our trauma-informed care and how we're going to approach it. And we are really just getting started and moving in that, and really kind of excited, looking at cross-functional work across the industry, or across the system, but really focusing on some key areas that we know have significant impact both in our staff and our patients every single day. Next slide, please. So what is We Care? So We Care is frontline staff, recognizing that we are so busy that it isn't always easy to stop and take a break and move away from the situation, or even leave that care area, because we have patients to take care of. And so we've trained local level supporters on how to respond to incidents within the unit that may be occurring, that really could be addressed at that frontline peer level. So did some training with that group, trained that group plus a few others on how to respond to events across the health system. It could be something as maybe a bad outcome, or maybe a patient passed away unexpectedly. It could be something that's happened within the unit. We've had, unfortunately, a number of our colleagues that have passed away, or just had a trying event. And so we trained them that within 24 hours, how do they respond to that care area? We have multiple different things that we do and bring, and sometimes it's just listening. Sometimes it's just hearing what they have to say. And then the third tier, and this is really ran through Dr. Nadine Caslow and a few of our other team members on a larger group. This is where a whole unit needs to be impacted, our physicians, our nurses, our other colleagues. And so really having a We Care response, a debrief at the end of our shift, and really understanding the trauma and how that impacted and how we can support our frontline teams. Next slide. So how do we train our staff? What do we do? So we really talk about wellness and trauma and really understanding that it's threefold. One, what do we, Grady? What's our organizational responsibility to ensure that we are providing the platform, the framework for our teams and our patients to be successful? Department, what are the departments responsible for, and how do we interact at that level, and what support do we as executive leaders provide to each of our departments to ensure that they have the ability to understand trauma-informed leadership and trauma-informed care? And then self-care, because we can't expect everyone, we can't do it for everybody. And so really training and helping people understand through awareness and other tools and providing connections for our frontline staff to be able to understand well-being, resilience, and how trauma has impacted them, which then translates into being able to care for our patients. Next slide, please. So where are we now? This has been great. So community resilience model, we've had actually 2 sessions, one with the Emory School of Nursing and one with some of the grant funding we actually have received. I'm a trainer. It's probably some of the absolute best training I have ever gone through. I went to it, and I've heard this from so many other people that have gone through the training, went to the training to find out how I can support my team and our staff and our patients better. In reality, as I end up helping myself a whole lot more. And so it's been really good. So we had our second wave just completed in February. We are doing CRIM training all across the institution. We're doing it in new hire orientation. We have departments checking in on it. We did some work, one of our team members did some work at our neurostroke support group not too long ago, and really just fundamentally helping people understand how that can help impact them. And so really our goal in alignment and working with Cammie's team that's here and our team, how do we train the trainer? How do we roll this out throughout our institution? And so it's really caught fire and really caused a lot of excitement on how we know we can support both our frontline staff and our patients every single day. That Natalie, are you there to ask our question? See if she was going to jump on.
Yes, I'm here.
Oh, there you are. Good. So Natalie is my partner in crime for this.
Yes.
Natalie Updike and I have been working, and she can introduce herself as well, but she has our question for you.
Yes, good morning, and thanks so much for letting us be part of this. So you heard Michelle talk a lot about how we are building resiliency among our team and helping them identify when they need to take care of themselves. And so our question to the group is, so what is your favorite sort of go-to self-care strategy when you're having a tough day or you just need to reset? What's in your toolbox to help you do that?
Great. Thank you all so much.
Thank you, Michelle and Natalie. And thank you all for adding your tips to the chat. I love this kind of engagement. Next, we are going to hear from Resilient Middle Georgia and our close partner, Dr. Andrea Meyer-Stinson. She is a PhD, LMFT, Associate Professor of Psychiatry and Behavioral Science, and Associate Professor of Peds at Mercer University School of Medicine. And she's going to be talking about the trauma-informed work they're doing with primary pediatrics practices. And Andrea, thank you for being so close to us and talking to us day in and day out and not getting sick of us.
I'm happy to be here. Hopefully y'all can hear me okay. Yes, I'm going to first start by introducing my team, because none of this work is possible without them, and our team expanded so much in the last year. So we started this work back in 2019. We were one of the first funded regions, and Jill Vanderhoek and I spent many months doing this work on our own. And it's been amazing, but having more capacity makes us able to do more. So we have hired a project manager, Amanda Juarez. Next slide. And we've also brought in some additional team members. We were awarded a Public Health AmeriCorps member for the last year, and Deborah Jackson, and she's been our boots on the ground, building community relationships and outreach. Doris Opong has been a valuable team member, and she's focusing on coalition building and data evaluation. And then we have an intern from Texas A&M. Next slide. So briefly, this is who we are. We serve a 14 county area. We've been doing this work for 3.5 years, and it's just been amazing and wonderful and challenging and all the adjectives in between. We really have been focusing mostly on building our network of leaders and informing the community about positive and adverse childhood experiences. We have so many relationships we've made. Next slide. These are our accomplishments from last year's annual report. We're very, very proud of this work, of our coalition members, of the trainings we've offered. So 26 evidence-based trainings across Middle Georgia, over 500 participants with outreach materials to over 6,000 individuals. And we just keep pushing forward. Next slide. So I'm going to talk really briefly about primary pediatrics. Next slide. Primary pediatrics is the largest outpatient pediatric practice in Middle Georgia. They have 5 offices, over 25 medical providers. They offer sick and well visits. They offer aftercare, child life specialists, primary parenting. They have a family pharmacy in Macon, and they have in-house lab services. Next slide. So as many of you have mentioned previously, this is a journey and it's never ending. And I wanted to show you all the trauma continuum, because I believe when we're talking about this work, it's really important to identify where you are in this process and how you can continue to repeat through these cycles. So in our work with primary pediatrics, we're really in the first phase. And I'm happy to say that, and I'm proud to say that, because we've been working hard to get there. But this is an ongoing organizational shift that, it requires constant feedback loops. And you never, ever, ever achieve trauma-informed 100%. You're always going back and asking questions and checking in. Next slide. So here's our timeline. We started this relationship back in 2021 when we actually had contacted Primary Peds about a DECAL grant for early childhood mental health. And I was able to make contact with the office manager, who's been one of our strongest champions. In 2022, we started by just giving a general presentation, an hour-long presentation based on Connections Matter. And we did that in March. After that, we just began having meetings, getting together with folks in the office that the office manager felt like could be champions within their office. In that time, they made some changes within the office, and this was just in the Macon office, which is the biggest office. We participated in a huge pediatric health fair that we helped them to organize and plan. We met with the president of the office in Macon, and then we also had 4 additional Connect Now presentations. We also contracted with an organization I'll talk about briefly in a moment to start introducing some other changes in the office. We have continued the relationship. It takes time, effort, and consistency to do this work. And building those relationships is just so important to this process. Next slide. So I wanted to give you a little bit of information about the awareness trainings we did and what we found. And so overall, since we started this partnership with Primary Pediatrics, they've created 3 new positions. So They created a new social work position that they did not have before. They created a mental health nurse call line that they did not have before. And they actually just started working with Mercer to have a mental health provider, behavioral health consultant intern in the practice. After those 5 awareness sessions, we actually did pre and post assessments to see how folks were feeling about the information. And we had over 95 participants take part in just the Macon office. 30% of those were medical providers. The remainder were not. And if I can say anything today, is to just remember to focus on the whole package. Medical providers are important, but medical assistants, front desk staff, lab technicians, custodians, they're as important to this work as the medical providers are. Some of the feedback they said after the training, it will help me speak more with more empathy and patience. It will help me to practice patience, love, and compassion to children and parents in all situations and provide resources. And I will work to know different aspects of my patients' lives so that I can see their health as a whole. Next slide. So really briefly, this was our pre-test survey results. So about 66% of the folks we surveyed or that responded to our survey did not have any awareness of ACEs before we started this process. Next slide. After 1 hour of training, which is very brief and doable, majority of them felt very aware or somewhat aware. So we know 1 hour training can increase awareness significantly. Next slide. We also asked them, to what extent do ACEs play a role in the health and well-being of the families in your practice? The majority of them beforehand said they weren't sure. A good chunk said very important. Next slide. And by the end, 90% of them said very important. So you can see that the value in this information was really adapted after they took the 1 hour training. Next slide. So I want to just stop for a moment and talk about where we see this work going. And truly, we see 2 worlds coming together in our pediatric work. We see the importance of integrated behavioral health and trauma-informed care. So trauma-informed integrated health care focuses on the prevention, recognition, and response to trauma-related difficulties through collaboration of physical and mental health professionals with the child and the family. And this can be achieved by co-location of medical treatment, mental health care, and social services in the healthcare setting. Streamlined communication between providers and partnerships regarding treatment decisions. We know, and most of you all know this as well if you work in healthcare, that trauma-informed integrated care is cost-effective, and it also leads to enhanced patient access to services, improved quality of care, and lower overall healthcare costs. So we believe our work isn't just about trauma-informed care, it's also about building integrated behavioral health alongside the trauma-informed care process. Next slide. So how do we do this? Well, I don't get paid by the Collaborative Family Healthcare Association, but I am a member. And we have really leaned on the expertise of others, because if others have already done this work, we don't need to reinvent the wheel. So we have worked with CFHA to help connect us with a subject matter expert who is Dr. Charles Scarborough at Christ Community Health Center in Augusta. He's a pediatrician working at an FQHC there who is fully immersed in the integrated behavioral health approach. And by creating this partnership with CFHA, we can lean on the resources that already exist to do this system change. Next slide. Just briefly want to mention, we finished our leadership collaborative with KinShift last month. Next slide. We had 2 healthcare providers or healthcare individuals participate, one of which was from Primary Pediatrics. This was a 6-month-long leadership training towards effective trauma-informed and anti-racist project implementations in healthcare settings. So what we were seeing as an organization, an initiative in Resilient Middle Georgia, is that people wanted to move this work forward, but they really needed support and help to do that. So we took in 13 leaders of our community. We met with them monthly, and we provided coaching sessions with experts at Kinshift. And we also have funded them towards projects that they're going to implement as a result of this leadership collaborative. Next step. So I'm not going to read all of this slide to you, but at Primary Pediatrics, Gabrielle, who's the nurse there who participated in our leadership collaborative, is going to use her funding to pilot a stress vitals project. As most of you know, when kids come in for well visits or sick visits, they always get their vitals done. You know, we've normalized heart rate, blood pressure, temperature, height, weight. Why not normalize stress? Why not ask about stress at every visit as part of the vitals? So we're going to help her do that, or she's going to pilot that on one hallway. And she's going to pair that with developing some resources and some procedures to refer families to that intern at the office if they are having significant stress in the family system. Next slide. So where do we go from here? So much work to do and so little time. We're really hopefully going to focus on moving from that awareness level to the trauma sensitive level with more trainings and more collaboration with Primary Pediatrics. We also have been talking with Dr. Stan Sonu about a relational health poster project that would happen at Primary Pediatrics as well. So this would be in addition to the stress vitals taken for every family and child coming in, that we would teach the staff and physicians and medical providers there that you can use this relational health poster to talk about not just what adversities are, but what positive experiences can help buffer against those adversities. And we do know that we need both. We need to have both conversations with our families. We're also hopefully going to work with CFHA and Primary Pediatrics, pending some additional funding for this project, to help them hire a full-time behavioral health consultant for the Macon practice. So hopefully once we can get that going, Primary Pediatrics can better understand the model of integrated behavioral health care, how that works in their particular setting, and then can amplify that position across all 5 of their pediatric practices in Middle Georgia. And I think that's it. My question is, who wants to join me? I would love to start a statewide community of like-minded healthcare professionals interested in making integrated behavioral health and integrated trauma-informed behavioral health the standard of care in Georgia. And it's possible to do this, y'all. We can do this. So please respond in the chat with your name, title, and an email address. And this is our call to action, and we'll get together and make this happen. I want to just say briefly, thank you so much to Resilient Georgia and Patelic Foundation. Without your support and encouragement and a shoulder to cry on at times, none of this would be possible. And we're just really grateful to have this opportunity. Thank you.
Thank you so much, Andrea. So impressive. Next, we are going to hear from Pamela Mason, who I have had the pleasure of working with for years. She's such a fun person, and I'm excited for her to present. She's an RN and the executive director of the Pediatric Healthcare Improvement Coalition, PHIC for short. And she is also the affiliation operations director at Children's Healthcare of Atlanta. So Pam.
Hi, can you hear me okay?
Yes, ma'am. Perfect.
Awesome. Okay, so thank you, Emily. Yes, Emily and I worked together a long time ago at Children's, and it was fabulous. But I am talking to you today as the executive director for PHIC. PHIC is the Pediatric Healthcare Improvement Coalition. A little background on PHIC is that they started way back in February of 2013 and came together as a non-for-profit. And then the next year, they were able to achieve a 501c4 status, and we still have that status today. Originally, they were created to focus on a new model of care, just focusing on pediatrics, and they wanted to do three things. They wanted to improve quality, they wanted to manage costs, and they wanted to improve access. Since then, things have changed, and next slide. They are now a coalition of 5 children's hospitals within the state of Georgia, and their focus now is to better improve health outcomes for children and to sustain quality and pediatric care. Next slide. So this is what we look like. We have, we are made up of 5 children's hospitals, like I said. They include Children's Healthcare of Atlanta, the Beverly Knight Olson Children's Hospital in Macon, Piedmont in Columbus, the Children's Hospital of Georgia as a part of Augusta University, and the Dwight and Cynthia Willett Children's Hospital in Savannah. Each hospital has a board, 3 board members that represent them. And they also have a community member, and she is a physician who works, a pediatrician who works for Morehouse. In addition, they have 2 non-voting members. They have their past chairperson and then their past vice chairperson. So those are their stakeholders. We meet monthly, and in those monthly meetings, they report off on what is going on in their hospital, what types of children are they seeing, what are barriers to getting care? You know, do we have staffing issues? Are we struggling with nursing issues? How are we getting more staff? And they also report off on their committees. So each board member is required to sit on a committee, and each of the committees meet monthly. So as you can see, the committees they focus on quality, emergency preparedness, advocacy, and communication. So I wanted to highlight the key focus areas for the past year and for this year, and just to help you understand the amazing work that these physicians are getting accomplished. So communications is chaired by Dr. Catherine Cheek. She is out of Columbus, and a huge focus on them is accessing the medical record in pediatrics. The first focus is around kids who are in foster care. So one of the struggles that pediatricians have is that children will come to their clinic and there is no record on them. So current state is the practice will log into a system that is managed through GHIN, which is our Georgia Health Information Network. And in the best circumstance, the information on the child is there. What medicines they're on, have they had any surgical procedures, have they been to the emergency department? But the hardest scenario is when there is just no information there. So this committee works to highlight where are we struggling and why are we struggling, and how can we better access the medical record. They participate in many crossover sessions, so they will have a child that they have seen in their pediatrician office, and we will go through a scenario where other pediatricians then try to find that patient as well in their medical record. And if they can they see the same information? And if they can't, then what are some solutions so that they will be able to? The other piece is they have been called in several sessions to help educate our legislative officials. They were called to present to the Behavioral Health Reform and Innovation Committee, which was a subcommittee of the 1013 bill. And they were able to share their experiences with kids, not only in foster care, but their other struggle is around accessing the records of behavioral health children. And that issue is that in behavioral health, many of the records are on paper and they are not in Epic, or I'm sorry, they're not in an EMR. And there are a lot of consent rules around what can my pediatrician see, even if I've referred my child out for a behavioral health consult, whether it's psychiatry or psychology. And there are lots of barriers to being able to understand what is happening with these kids. So they have been able to go to Dr. Noggle's office. They've been to Commissioner Tanner's office, and they've just been able to speak to these struggles. The next committee is advocacy, and they actually have partnered with Resilient Georgia. You might know of them. And their focus is on addressing behavioral health issues across the children of Georgia, especially in primary care. So together, they wrote a grant to apply for funds in order to allow pediatricians across the state access to the REACH training. And as you know, the REACH training is the resource for advancing children's mental health. Their first cohort came out of Augusta, and they were able to train 37 practitioners and physicians in this training. And they found it to be an amazing training that helps them to be more comfortable with dealing with children that have anxiety, depression, and ADHD. And what we've been able to see is that the practitioners are more comfortable dealing with these initial diagnoses. They're more comfortable with dealing with prescribing of drugs that could help. And that helps alleviate the burden of finding a pediatric psychiatrist or psychologist to help these kids. And so they're able to be able to handle kids that are like low depression, low anxiety, and then be able to save their referrals to more complex kids. Their second cohort is, like Emily said at the beginning, it's in May, it's out of Columbus, and they are currently accepting applications for clinicians to take that training in May. So that is the work that advocacy is working on. Next slide. The other two groups are quality and emergency preparedness. So in quality, their biggest focus is around the Antibiogram Project. And they developed using the microbiology leaders at each of the 5 hospitals, they were able to gather a bunch of data on what are infecting our kids, depending on where you live in the state, and what are the best antibiotics to help that infection. And through our website, there is a link to the Antibiogram Project, and physicians across the state are then able to access, depending on where I live, what is infecting our kids and what is the best antibiotic to help them. And then the last group is emergency preparedness, which is led by Dr. Natalie Lane out of Augusta. And this group advocates for making children a priority in a disaster. So whether that is in creating disaster plans at your hospital, whether it is engaging in EMS and making sure they understand kids when they go to pick them up, it's around education. This group is on a mission to make sure that there is a pediatric partner who is on every healthcare coalition to make sure that kids are represented in these areas. So my last, my question for you is, think about a time when you or a loved one was in the hospital, and what was a positive experience that you had while you were there? And that is it. So thank you for your time today, and have a great afternoon.
Thank you, Pam. And next, we are excited to hear from Dr. John Constantino. He's the Chief of Behavioral and Mental Health at Children's Healthcare of Atlanta. He's the acting professor at the Department of Psychiatry and Peds at Emory School of Medicine, and an adjunct clinical professor of psychiatry and behavioral sciences at Morehouse University School of Medicine. We'll also hear from Tammy Bartlett Sherman. She has an MBA and an MHA. She's the Vice President of Behavioral and Mental Health at Children's Healthcare of Atlanta. You've got like 9 titles between the two of you. Welcome, Dr. Constantino and Tammy.
Well, Emily, thank you so much. And it's great to be with everybody today. Tammy and I are very pleased to be part of this forum. And I just want to thank Resilient Georgia and really the extraordinary cast of speakers and participants in this. The chat has been great to just follow and you know, kind of feel the energy and the mission that everybody is engaged in here. So I'm a child psychiatrist and a pediatrician, and one of the ways that we have been thinking about trauma-informed care is that essentially it is a sort of trauma into itself, that when a child has a mental health condition, it is so common for them not to have access to what would be considered by a health system medically necessary mental health care for that condition. And I think everyone is familiar, you know, with this situation. We've heard, and if folks could mute their speakers, I think there's a little bit of feedback on the line. You know, we've heard talks today about institutions and services adapting trauma-informed practices. We've heard about really distinct models of trauma-informed care, including the life care specialist, the role of integrated care, and also great to hear from our colleague Pam about, you know, this sort of coalition that is encompassed by PHIC. But what I'm going to open with the question that I would like to think about, and that is what I'm going to present a view from the standpoint of the individual. One of the speakers mentioned the whole package of care that is necessary for mental health services in integrated care, as an example. And what I want to ask the audience today is to think about the question, what else should children be thinking about? And what Tammy and I are going to present is a very brief snapshot of how we're thinking about the issue of resolving the fact that mental health conditions, which are a long game for most children, most serious mental health conditions start early and last long. And so thinking about how we can elaborate in a health system a type of care that owns those mental health conditions, just like we own, for example, a medical condition of a child. You know, when a child has diabetes or cancer, that we don't sort of send them to 7 different places. You know, we take care of that condition in a health system. And why isn't mental health care that way when it's medically necessary to resolve a mental health condition of a child? So that's what I'm going to talk about. And our program, and actually my being in Georgia, is predicated on 2 kind of seismic events that reflect what I believe is a sort of solemn collective responsibility of all of us on this call today. The first is that Children's Healthcare of Atlanta decided to take an unprecedented amount of its resources and plunk it down for child mental health as an endowment, $500 million. I don't know of a health system that has done that. Certainly lots of money is spent by health systems on mental health care, but this was to subsidize new behavior and mental health programs for children in the form of an endowment that would continue a subsidy over years of time. And then the second was the mental health parity bill. And so the question was, could we model what it would look like if mental health care to a child looked like medical care? In other words, that we're owning the condition in the same way, we're getting at it from its start, and we're sticking with the family for all aspects of care that they need, not sending them to different places unless we can fruitfully collaborate with the community. In other words, but making sure that all aspects of care are attended to by either us or our collaborating partners. Next slide. So the question becomes, which kids do you address in a new model of care, where still, even with a lot of resources, you have to make tough decisions about which kids will we model, for whom will we model a different, a transformed way of delivering mental health care. And so this is a little graphic that shows kind of in one slide, just if you think about the existing ecosystem for mental health, and if you think of all the kids on the top as the population who are at risk for mental health conditions, and when you think about the fact that we have established in the community prevention programs, medical homes, schools, outpatient mental health services, inpatient and residential treatments of very good quality. We have lots of great things going on in the community, many of which you've heard about today. But then, of course, there are also significant gaps, and those gaps have to be filled. And so one of the things that Children's wants to do is identify children along these various gaps and model what would it be like if the conditions for which those children are either at risk or showing early signs of mental health conditions could be owned in a way that the full evidence base of mental health care is delivered to improve their condition and really ease the burden on our municipal safety net, which is overburdened with kids that are falling into the net because they're not getting the care that we know is evidence-based and they need. Next slide. What does evidence-based care look like in child mental health? You know, if you categorize it, it's a relatively short list. We have 2-generation mental health services, parent-child interactional therapies for young children, the psychotherapies, psychopharmacology, substance use disorders, and more recently, dialectical behavioral therapy as an evidence-based form of care for children in crisis, particularly to prevent what is one of the leading causes of death of children, which is suicide. And we have this particular kind of therapy and mode of therapy, which so many kids who are in that category never see the light of day. And each of these, as you know, requires trauma-informed approaches to families to engage them and children, trauma-informed lenses through which to deliver this care, and also case management, family support services, social supports, which represent the complete package of ownership that would entitle a child to have the full evidence base of what the field of mental health has to offer. But as we all know, from our different vantage points, it is most common for this kind of care to come too late, too low a quality. And if you are in the situation which most kids with serious mental health liabilities are, that you need more than one thing, you may get one thing that you need, but get put on the wait list for many others. And so care is fragmented, it's inefficient, we're spending a lot of money, and a lot of kids are falling through the cracks in the context of this kind of fragmented care. And so what Children's aspires to do, and again, I want to get back to my question, I'll remind you of my question, which is what should we be thinking? But what we're thinking is that we should model what the complete evidence base delivered to a population of needy children, as many as we can get to, and it won't be all of them, at first at least, but to model what that kind of care should look like, to work with our partners in the community to make sure that any kid that we are incorporating into this system for care, this ownership transformation model of care, that we are working with all of you, and any place where any of us are falling short, that Children's tries to do what it can to make sure that the entire evidence base is available for this flow, this cohort of children. And the hope would be that that cohort gets bigger and bigger and bigger, where we are all working together to make sure that kids get the full complement of care. Okay, I'm going to give an example of this and an innovation, and then Tammy's going to talk about one of the gaps, which is the primary care medical home gap, where I think you've already heard about the importance of integrated care and arming and empowering primary care programs to be part of this solution, for the public health solution of initiating mental health care for children. And we have programs in that, and we are invested in that, and we want to be invested across all of the gaps, so that we're modeling for at least this subset of kids that we are at first pass, that we're going to try to reach and continue care and treat mental health care for children as a chronic disease kind of situation, where we're not giving up until the condition or the risk is resolved, or the child passes through the threshold to becoming an adult. I want to give an example of this, and then I'm going to turn it over to Tammy. Next slide. So this is an example of a multi-dimensional program of care that almost never happens. And the only reason it could happen is because it was subsidized. And this is a kind of an example of what you can do with a subsidy. that, again, that is this seismic event that Children's Healthcare of Atlanta plunked down a discretionary endowment to pay for what otherwise doesn't get paid for. And this is an example of a flow of about 500 young children, birth to 6 years, who had been placed in protective custody for child abuse for a first time in their life. And this was a program in Missouri that before I moved to Georgia that I directed. And it's the program is 10 years old. And for the children who were placed in protective custody, what this program did was it promoted reunification of children with their birth families and was successful in doing that. And in the process, delivered parent training, delivered parental psychiatric care when parents needed and wanted it, did developmental screening, coordinated with early childhood education programs so that children in the context of being reunified with their families were accessing early childhood education opportunities when relevant, and working with the courts and judges to make sure that when families were reunified, they had all the material needs that they required to be successful on the basis of medical recommendations from people in child development, clinicians who are following the families. Now, most of this, if you think about it, doesn't get paid for by Medicaid, or doesn't get paid for very well by Medicaid. If you think about this listing, parent training, okay, the treatment of parents, the screening and coordination with education programs, working with the courts, none of that really falls into a CPT code. And of course, we got reimbursement for medical services for the kids as well. But what happened was that this was on the basis of a longstanding government grant that subsidized this care. And just to make a long story short, we followed the kids for 10 years and showed that after they were reunified, that the likelihood that they would re-enter child welfare was cut fivefold, from 30% in care as usual, that the children would end up back in the child welfare system, to 5% or less, following them up across the entire state of Missouri and any court in Missouri for 10 years. This is about to be published soon, but the point is that when you integrate care, when you defragment it, when you subsidize what it costs to do what the evidence base says to do, and all these are evidence-based practices, parenting training, treatment of parents, developmental screening and early developmental therapies, early childhood education, and making sure that parents have what they need to keep their children safe. Like we all know that those are important things to do, but they don't always get paid for as a package. So that's just one example of why we want to, case by case, and thinking about children as from the time that they enter an episode of care, how do we own the evidence base for endowing them, circling them with all of those evidence-based elements of care. And our hope is to work with all of you, and not to do it all ourselves. We want to work together, but to bring these to bear for a larger and larger and larger cohort of children. That is the model that we hope to elaborate here and study as a function of this impact over time, and that we hope for great partnerships with you all. Tammy's going to take it from here and go on to what our current efforts are in that first gap with primary care providers. Next slide.
Thanks, John. Well, I think the hallmark of this gathering is about collaboration and partnerships, right? So as Emily and Pam have already talked about, we really want to empower the local pediatricians. So through collaboration with Resilient Georgia and PHIC, with support from Aetna, they're collaborating with the Reach Institute to train rural providers in behavioral mental health. They've done one session already, and the next session is coming up in Columbus on May 19th. Next slide. It's really about empowering these providers, not only improving their comfortability in dealing with mental health and talking about mental health with their patients, but improving their satisfaction as well as the patient satisfaction. And we'd all like to see decreased emergency room visits for mental and behavioral health conditions, as well as patient compliance with treatment plans, and hopefully leading to reduced costs and increased revenue for those pediatric practices. But that's just one small way we're empowering the pediatricians in the rural areas to hopefully impact the kids in their area through those partnerships. And that's it for now. John asked our question for us, so we're going to be looking at your responses.
Thank you so much. Next slide. So we are again, glad that all of you joined us today. As another reminder, we will be sending a follow-up document with all of your questions, all of the content, all of the responses from all the wonderful questions we had throughout the session today. If you have not joined our listserv, please log on to our website. You'll get a pop-up to join to add your email. So you'll be invited to all of our meetings going forward. We're excited to see you at our next general meeting in November. That information will be coming out soon. And if you do not follow us on social media, please do. We would love your follow and to also share your work and all the important things that you are doing. So please also message us regularly with any updates that we can promote across all of our communication channels. Thank you to everyone. We are so grateful for your partnership, for all of the many collaborations that are going on across the state, and for really focusing on being trauma informed in all areas of work that you're doing. So we hope you have a great Thursday, weekend eve, and we will see you next time. Have a good day.